They are unaffected by comorbidities such as kidney disease. All right, and let's move now to the introduction into Alzheimer's disease. These are my disclosures here. All right, so Alzheimer's disease is a terrible, devastating, and progressive disease. It starts with very early and prominent episodic memory impairment, and then it affects other functional domains, and it also later changes the behavior and personality of the patient. There are typical characteristic pathophysiological changes underlying those clinical features, which start with amyloid pathology. After that, it leads to accumulation of the tau proteins, phosphorylation, and then accumulation of tau proteins in forms of neurofibrillary tangles. And all this inevitably leads to neurodegeneration that starts in the entorhinal cortex and then it spreads throughout the neocortex. We have now biomarkers that can measure those pathophysiological changes, for example, in fluids such as cerebrospinal fluid or blood tests, or imaging such as amyloid PET scans, FDG PET scans, or MRI. Symptomatically, typically at the beginning is asymptomatic phase, where you can already find changes at the biomarker level, which is called a cognitively unimpaired phase. And then from the symptomatic phases, the first stage is mild cognitive impairment, which later progresses into mild, moderate, and severe dementia. So even with all these biomarkers available and being in 21st century, we still have Alzheimer's disease heavily underdiagnosed or never diagnosed. And this causes missed opportunities for patients, for treatments, for care and follow-up planning. So we need to take care to try to diagnose earlier and accurately those patients. And just to give a number to it, there is about 8% of MCI detection rate based on the study run in US, and in Europe it's about 10%. So without further ado, I will give it now to Dr. Duzel to introduce us into the world of digital cognitive assessments and how together with blood, those tests can help us diagnose Alzheimer's disease earlier. Here you go, Dr. Duzel.
Thank you. Hello, it's my pleasure to talk about integrating digital cognitive assessments and blood tests for early Alzheimer's disease diagnosis. My name is Emre Duzel. I'm a neurologist practicing in Germany. And it's my great pleasure to discuss these emerging technologies that are now becoming available, particularly also in how general practitioners and neurologists can work together. And I'm very happy that today we have a neurologist in my person and Dr. Dali as a general practitioner here in this webinar. These are my disclaimers. I'm giving this presentation on behalf of Lilly and I've been compensated by Lilly. I'm also co-founder and chief medical officer of Neotev, which is one of the technologies we will be talking about today. So let's start with the syndromal diagnosis of mild cognitive impairment. As you all know, mild cognitive impairment is an impairment of, in most cases, memory function, where in neuropsychological assessment we have a deficit of 1 to 1.5 standard deviations below the age-related norm, and individuals who come for for mild cognitive impairment usually come with worries about memory decline, but their independence in everyday life is usually preserved. It is actually not a mild cognitive impairment from a patient perspective, and also not a mild cognitive impairment if you actually look at what's really happening in the brain. So the journey of patients usually starts with worries about memory decline. Then they usually often come to a primary care physician, which then makes a referral to a specialist. and then a further referral occurs to a memory clinic. And before a diagnosis is actually made, so we suspect MCI, in most cases 80% due to Alzheimer's disease, before a diagnosis is made, people can experience delays of 1 to 2 years until either the diagnosis of MCI is confirmed. The one reason is that the referral from primary care physicians to specialists to memory clinics often doesn't involve the proper cognitive and biomarker-based triaging. This leads to an overburdening of memory clinics. There are very long waiting times. We have high costs associated with unnecessary assessment at the specialist and memory clinic level. This also leads to regional inequality because specialists and memory clinics are less widely available than primary care physicians. And of course, appropriate treatment options are not implemented and are delayed. This situation is contrasted with the acknowledgement from national and international guidelines that there is really a need for early syndromic and etiological diagnosis. So the German guidelines, I think, have been quite spearheading in this, in that they said if somebody comes with a potential diagnosis of mild cognitive impairment, it's really recommended to establish the diagnosis or rule it out. So early syndromal diagnosis is very important. And if a patient has MCI, then the recommendation is to also establish an early etiological diagnosis, so determine the cause of what's leading to MCI with the appropriate biomarker assessments. And if you suspect Alzheimer's disease, of course, the biomarkers are related to amyloid and tau. Now, we have a very exciting time that we are experiencing because we are having new technologies that we are seeing now being implemented in healthcare. And these are digital cognitive assessment technologies and blood-based biomarkers. And the way we can implement these into the patient journey of Alzheimer's disease is still evolving. We are all trying to understand what's the best patient pathway. This is an example from a recent study that was conducted in Sweden, where they implemented a digital cognitive assessment at the level of primary care physicians, and this was then followed up by a blood-based biomarker test. And of course, in reality, it's not as straightforward and as simple as displayed here, but in principle, we have a clinical evaluation that's followed by a digital cognitive assessment. And if the patient is cognitively impaired, then you can do a blood-based biomarker test. And this then either confirms Alzheimer's disease pathology or you have an exclusion of Alzheimer's disease pathology. And then this can lead to further clinical management of the patient. Now, the digital cognitive assessments is something that I will now focus on for the remainder of the talk. They serve several purposes. They, of course, are important to improve the syndromal diagnosis of mild cognitive impairment. So identify patient at the earliest stage of Alzheimer's disease. But they are also, in particular if they are remote technologies, can improve the cross-specialty referrals. So the intersectoral cooperation between primary care physicians and neurologists can be particularly improved with remote digital cognitive assessments. Timely remote digital cognitive assessments can prioritize transfer to specialized diagnostics by having a triage of mild cognitive impairment that's robust. And they can enable the precise allocation of highly specialized resources at the specialist and memory clinic level. And in our experience, they can also empower patients. We feel that patients feel more engaged, more empowered when they actually are actively self-administering tests at home and contribute to the diagnostic assessment. And of course, they are an important way to scale the sheer number of assessments that the healthcare system can provide. These, new technologies, and that's always the case, and that's the same for digital technologies and also for blood-based biomarkers. When you bring new technologies into healthcare, you need to define acceptable standards. And there are, fortunately, international working groups working on these standards. And there has been a recent publication on digital cognitive assessments that are clinic-based, so on-site, so done in the GP office or the specialist office or the memory clinic. And the Global COI Initiative just published for these on-site tests some recommendation for a detection use case, for a diagnostic aid use case, and for a profile characterization use case. And the same is now happening also for remote digital assessments, for tools that patients can use in their own hands, on their own device, in their own in their home environment. And here's just an example, an excerpt of the new technologies that are emerging. I want to dive a bit deeper into smartphone-based self-administration of cognitive tests. And here I want to talk about the Neotive Care tool, the Neotive Care tests. Now, the Neotive Care tests are used on the patient's own smartphone device. Here you can see this, screenshots from the tests that are implemented. There are 3 different types of memory tests in the Neotive Care app that the patient can do on their own, without supervision, on their own smartphone. And the tests are designed in a way that they target certain brain regions in the brain. So they measure the function of certain brain regions in the brain that are related particularly to memory and executive function and visual processing, and that are, as we know, affected by Alzheimer's disease pathology, where it starts and how it spreads through the brain. So one set of tests is that you can see on the left, focus on visual memory discrimination, so accurate visual memory. A second set of tests that you see in the middle are focusing on object and spatial information integration. So there you have to memorize where objects are located in 3-dimensional spaces. And another set of tests that you see on the right are focused on familiarity recognition. So the feeling that I know something, that I've seen something before is tested in that type of test. The way this smartphone-based self-assessment works is it requires a HCP-based indication. So when the patient comes to the healthcare professional, primary care physician or specialist or memory clinic, the HCP takes a clinical history as outlined before, and then when there is a suspicion of mild cognitive impairment, can prescribe the test. The patient then performs the tests at home. The way the Neotive Care app is implemented is that patients do 1 test per week. It takes roughly 15 to 20 minutes per week over a period of 6 to 12 weeks. So each of the 3 tests is repeated at least 2 to 4 times. And this is for the patients quite relaxing. There is some redundancy in the number of tests. They don't feel stressed. And we have the possibility with the Neotive Care app to actually assess memory function over a longer period of time and not just get a single snapshot in a stressful situation, maybe in a memory clinic. And then the app provides a results letter that the patient can send with a simple button press per email to the healthcare professional. And the bottom line is that the test result can help the healthcare professional to determine whether this is MCI-grade memory impairment or not. This is an overview of the findings letter. So if you focus on the right side first, you have the patient information, and then the app basically calculates a composite score. And the composite score is displayed on a ruler. There is a cutoff for normal and below normal performance. And if the patient's score is below normal, then you would suspect mild cognitive impairment. And then there's a second page you see on the left side where you see all single tests displayed with some feedback information for each test setting from the patient. They can communicate whether something relevant has happened at the time when they performed the test. And they can also communicate how well they concentrated and how they self-rate their own performance. So let me give you a patient story example of how such a test can be implemented. So this is a patient we saw in our memory clinic. He is 79 years old and he worried about memory decline over the past 1.5 years. His spouse described him as being independent in everyday life, although she has been handling his financials since several years, so it was not quite clear how, whether or not in mentally challenging situations he may actually be impaired. His MR showed mild atrophy with mild to moderate white matter hyperintensities, FACECAS grade 1 to 2, and there was one small right thalamic lacunar lesion. So he was prescribed a neonatal care test over 9 weeks, and this showed actually in this case a normal cognitive performance. So the patient's performance was above the MCI cutoff. We then decided not to do further diagnostic workup with the patient. And in fact, the patient was also, because we are in a memory clinic, also normal on neuropsychological testing. He entered a observational cohort study with the German Center for Neurodegenerative Diseases, and at follow-up assessment with extensive neuropsychological testing that we performed in this observational study, he was cognitively stable over 3 years. So this is an example where you have a patient with a memory complaint. It's unclear whether or not this can be mild cognitive impairment, and you can use such a digital cognitive assessment, in this case, to rule out mild cognitive impairment. In such a case, of course, we know that it is important also to do follow-up assessments. So if a patient is normal on a digital cognitive assessment, such as neonatal care, it's nevertheless important to do a follow-up after 12 to 24 months to see if there is any progression. So remote and repeated assessments are, I think, quite attractive for early diagnosis of mild cognitive impairment. The remote nature of the test allows a remote initiation of the test. So for instance, if the patient comes for a follow-up, you can initiate the test remotely, and then the patient already comes with the result to your follow-up appointment. And so follow-ups and monitoring actually becomes much, much easier. In the case of neonatal care, the tests are language independent because they are visual, and the test is available in many different languages. Because the patient has the findings letter, and because the prescription of the test and the discussion of the findings letter can be temporally separated, this can also streamline intersectoral cooperation between GPs and specialists, for instance. So local GP and specialist network can work out how they actually implement the test. GPs can prescribe it, and every patient can go to a neurologist to discuss the results, or the GPs can discuss the results themselves and then refer the ones that are positive. We also made the experience that actually, because the patients spend several weeks with the app, this provides important opportunities that you can actually harness to educate the patient about disease and maybe lifestyle risk factors. And this is also an important opportunity that single snapshot tests don't deliver. And as I said, because you're assessing over a longer period of time, these tests can capture or minimize the effect of bad days on your decision-making and management decisions. They are also, because they are remote, offer exciting, I think quite exciting, new ways to actually save further resources, particularly with general practitioners. So in this case, what we are evaluating around our memory clinic in our local networks is a collaboration with pharmacies. So here the idea is that the GP or at the pharmacy, there is some information exchange about potential memory problems. And then the GP can prescribe the app, but the onboarding to the app, the explanation of the app, and everything around the app then occurs in the pharmacy, just like picking up a medication from a pharmacy. The patient then conducts the tests at home and then comes with the results to the primary care physician or specialist to discuss the results. So from an HCP point of view, it's like prescribing a scan, and the patient then comes back to you with the results. And it's very resource efficient way of implementing cognitive tests. We are also together with the support of Lilly and in collaboration with the German Center for Neurodegenerative Diseases and the German Network of Memory Clinics are evaluating how we can implement such technologies in the handover from specialists to memory clinics and then combine them with blood-based biomarker testing. So in the Refer MCI Quality Improvement Initiative, we are implementing neonatal care in a specialist setting. So specialists prescribe the app when they suspect mild cognitive impairment. And in this case, all patients then go to a memory clinic and receive a guideline-compliant extensive neuropsychological assessment and the blood-based biomarker testing. And this then helps us to determine how much we can achieve a quantitative improvement in correct referrals from specialist offices to memory clinics. And the way this type of tool then is implemented in healthcare is also compliant with some of the recommendations that the CEOI is now developing for remote cognitive assessments. So we have new digital cognitive assessments, and particularly remote digital cognitive assessments that are used at home over a few minutes per week, but for several days or several weeks. I think they save resources for primary care physicians and also specialists, and while they save resources, enable in-depth assessment of cognition at scale. PCPs, primary care physicians, and other HCPs can in this way be empowered to streamline referrals and to improve how they cooperate. And in fact, they can really adapt the mode of cooperation to their own local needs and can design their patient journeys locally in the way they want to work together. And memory clinic specialists can, of course, support the adoption of digital cognitive assessments by informing their local networks and contribute to timely management and fast tracking of patients into their clinics. And with this, I would like to acknowledge the collaborators and funders, and thank you very much for your attention.
Thank you very much, Dr. Duzel, for this exciting presentation. It's actually great to see that digital cognitive assessments, together with blood tests, they are being integrated not only in the research studies like Refer MCI, but also in actual clinical practice.
Yeah, I thought it was really interesting that you also involved the pharmacist and another innovative idea.
All right, thank you very much. So now let's move to Dr. Daly, and she will bring us closer to what's general practitioner perspective on blood tests in Alzheimer's disease diagnosis. And here you go, Dr. Daly.
Thank you, Kate.
My name is
is Dr. Stephanie Daly, and today I'm going to be talking to you about general practitioner perspectives on blood tests in Alzheimer's disease diagnosis. This talk has been sponsored by Lilly, and I have been compensated for the presentation. You can see on the next slide that these are my disclosures. So what are we talking about today? Well, the first thing to talk about is actually what are the barriers to making a diagnosis of Alzheimer's disease, and particularly thinking about this in primary care. We have a number of things that actually affect our ability to make a diagnosis, and this starts with really those systems barriers. So we know that in primary care there are shorter number of appointments, and these are often time limited. There can be fragmented systems which can actually affect the way that we refer into specialists. Alongside this, we have a number of clinician barriers. So historically, clinicians haven't had the education that they need to make an accurate diagnosis. We weren't taught about how to do a cognitive assessment. And so because of that, we lack the confidence to be able to do it. The combination of these two things will mean that if the blood tests are available to primary care, either the clinicians won't want to use it, or it may not even be accessible to them. And then we have the patient barriers. So people are often hesitant to come and talk to us about their concerns because of stigma, misunderstanding, perhaps different cultural contexts, and the fear of losing their independence. So there's such an overwhelming number of things that we have to battle in this condition, but I'd like to step you through the ways in which we might be able to overcome some of these things. So what is Alzheimer's disease, and how does this relate to dementia? This is a common question and often something that patients themselves will ask me. Often people conflate the two things, and so they consider them one and the same. But actually, now we have the ability to make a diagnosis of Alzheimer's disease, which is a biological diagnosis, and then apply that to the symptoms that we're seeing in front of us. So dementia describes the symptoms, and Alzheimer's disease, the cause of those symptoms. And we need to understand both of these two things to be able to apply the biomarkers in our clinical context. So what does a blood test for Alzheimer's disease actually do? Well, it detects Alzheimer's disease pathology. There have been several biomarkers that have been studied over the last few years, but there is a clear blood test that has shown the most promise, and that's the p-tau217 test. And what that actually correlates to, although it sounds like it's tau, it actually relates to amyloid pathology in the brain, and it's a very good marker of neurofibrillary tangles and amyloid plaques. Previously, being able to study these things and test these things involved either testing it post-mortem or in recent years using CSF and amyloid PET scans. Neither of those things are easily accessible, and they're costly and in some cases involve invasive procedures and radiation. And so the implementation of a blood test actually brings the testing closer to the patient. So what kind of blood tests are available? You can see on the screen that several blood tests have actually been approved around the world. And it's really important when you're using any blood test that you know which one is available for you in your area and what they're actually testing. There are two tests available, so there's the p-tau217 and the p-tau181, and they actually are doing slightly different things. So before you use these tests, you need to know which one is performing what things. So for p-tau217, it's actually looking at a confirmatory test, whereas p-tau181 is more of a rule-out test. Before we even think about doing a blood test, though, I want to bring you back to some core principles. We need to actually define the clinical syndrome that we're seeing. So when we went to medical school, we learnt that when we see a patient, we take a history, we perform an examination, and we do investigations. And the exact same thing is important in this context. So we need to understand what is the Alzheimer's disease continuum. It's not just dementia. So if we start with dementia, let's talk about what that actually means. So dementia defines cognitively impaired people who are no longer able to function independently. That means that their cognition is impaired to the point that they can't manage their basic activities of daily living and their instrumental activities of daily living. Before you get dementia, you have this time where you have something called mild cognitive impairment. Mild cognitive impairment is described by changes in cognition that might affect more than one part of your cognitive function. So it could be memory plus language, or it could just be memory on its own. But you're using some compensatory strategies to be able to maintain your independence. So that's using things like diaries, reminders, and prompts to be able to stay as independent as possible. The important thing, though, about mild cognitive impairment is that there is objective change noticed. And that's noticed by family members, by the clinician, and in the cognitive assessment tool that we use. So let's take it back to that history and examination that I mentioned. When we're taking the history, we're asking questions about cognitive change. So we're asking about memory and language difficulties and visuospatial difficulties and problems with executive function. And we're asking that from the person themselves. We're then going to take a collateral history and ask the exact same questions from the person closest to the individual. After that, we're going to apply a cognitive assessment tool. And the purpose of that cognitive assessment tool is to actually see if there are objective changes. So we might use something like the mini mental state examination or the MOCA, and we're looking to see if there's a change. It's the combination of this assessment that then allows us to work out whether or not we need to do any further tests. If there are changes in cognitive function, we're going to do some preliminary investigations to rule out other conditions that might be leading to that change. So that's when we do things like check their electrolytes and check their thyroid function and do a brain scan. Once we have all of those investigations back, we can then think again, have we reached the pathological diagnosis? And if not, it's at this point that we might apply the blood test, the blood-based biomarker. Before you get mild cognitive impairment, you obviously have somebody who has no symptoms at all. And it's important that in this population, we don't use the blood-based biomarkers at this point because we don't know what they're going to tell us. We only want to use it in people who have symptoms that are objectively noticed. So why do we even bother identifying the pathology? Well, I think it helps the person understand the symptoms that they're experiencing and what that actually means for them. I think it also enables us to potentially direct people to more effective treatment modalities and potentially clinical trials. We know that there are many different pathologies that lead to cognitive change, and this is only going to tell us about one of them, but it will help us to understand whether there are any other pathologies there that we need to look for, particularly if a person experiences a negative result. It allows an earlier diagnosis so that we can implement brain health strategies that may actually help to improve that person's quality of life. And I think an earlier diagnosis also allows people time to plan and time to make changes in terms of advanced care planning and future considerations. How do we know if these tests are accurate? Well, they have been studied quite a lot, and so we know from those studies that they do reflect the pathology that happens in the brain. But the important thing to know is a test is only as good as the population that you're using it in. So you have to have used it in a population where you think there's going to be a high prevalence, which is why we do the history, the examination, and the investigations, and we only use the test when we think that there might be pathology there. Otherwise, it might be that we get a false positive result, which could actually be psychologically harmful for patients. But used in the right clinical context, these tests can be very useful. So what happens now? Well, currently we have a lot of uncertainty in the system. People aren't sure if their symptoms are something to worry about. They often wait a little while before they come and see us, and then we wait a little while trying to work out what might be wrong. We do the clinical assessment, but sometimes we're still hesitant because we're not sure, and that delay adds up to a significant amount of time. We'll usually do the investigations and the brain scan and the mini-mental or the mocker and then refer on to a specialist. And then there may be further delays because of the waiting times around the world to see a specialist. Eventually, we get the diagnosis back and we institute some treatment. But I see a different future. There's a possibility that we could use these blood tests in primary care to assist in triaging patients so that they actually get to the right clinic appointment at the right time. So the first part of this algorithm is just the same. So we're going to see patients, we're going to assess them, we're going to take a really detailed cognitive assessment, and we can do this over a number of appointments. It doesn't have to be done in one single appointment. We can structure it so we can do it over maybe 3 appointments. We bring the patient back, we talk to them about their initial investigations, and then we counsel them on doing the blood-based biomarker. We find out what their views are about it. We talk to them about the opportunities that having the blood test provide, and we see if it's something they want to go forward with. Once we have the blood test result, particularly if it's the p-tau217, there are 3 cutoffs. So there's a positive result that tells us that AD pathology is present. There's a negative result that tells us that AD pathology is absent. And then there's an intermediate result. And it's this intermediate result that requires absolute further testing so that we can confirm whether or not this is a true positive or a true negative. So I see there is a future where we can perhaps use these blood tests to triage people so that they can access a specialist in a more timely way, but not without suitable education of the practitioners who are using the test. I'd like to just talk to you about a clinical case example because I think we learn best from applying this in the real world context. So I had a patient who I'd been seeing for a year or so, and prior to seeing me, he had seen a specialist and been diagnosed with some mild memory change. He didn't have a specific diagnosis, and it was thought that this was static change. When he came to see me, I redid the whole assessment, taking the history and doing the examination, as I mentioned before. And on the second encounter, when I saw him with his wife for the second time, he mentioned and introduced me to his wife as if we hadn't met the first time, which told me that he definitely had some memory change. I used a mini-mental initially, and because of his educational background, he scored very highly on that. And so I repeated his cognitive assessment, looking for that objective change, and used a mocker instead. I counselled him on using the blood test and referred him on to have it done. And then when he came back, we discussed what it meant. He actually returned a positive result. And after further discussion with the specialist, this patient was referred for clinical trials. And so I feel like he went from a place of uncertainty, of waiting, of just reviewing every year, not knowing what the future held, to a point where now he's actually taking some action and has a better understanding of what the future might be. In order to do all of this, it's impossible to do it on your own. And as I mentioned, the system factors are really a big barrier for us. And in primary care, we really need to connect with our specialist colleagues so that we can actually enhance the communication that we have with them and build trust and relationships that actually enhance patient care. In my own practice, I have done this through case-based discussions, so talking to a colleague at their multidisciplinary meeting, talking about cases that I have seen and trying to get an understanding of what happens to them in the specialist setting, but also helping the specialist understand what the capabilities are in primary care. This has enabled me to have a more streamlined access to referrals that are urgent, which is really valuable for me and my patients. I've also spent quite a lot of time understanding what the community looks like, what are the other supports available for people, because we have to recognise that even once someone has seen a specialist, there's so much more that needs to be done to support that person with their diagnosis. But I think this collaboration and connection with other parts of the system is something that's only going to enhance patient care and needs to be done as a matter of course. People often remark that there are ethical considerations to think about with these tests, and that is absolutely the case. But in my experience, and actually in the evidence, we know that people do actually want to know what's wrong with them. They do want a more precise diagnosis. We have to know, though, when we're counselling people on these tests, do they understand what the implications are of a positive result? What would a positive result mean for that person? Are they psychologically prepared to have the test? And all of this is part of your pre-counselling assessment that you do. And for some people, they choose not to have the test, and that's okay. But we need to have made sure that we've asked these questions very carefully before we do the test. So, I do have some golden rules that I think everybody should think about. One is, the clinical assessment is paramount. We need to understand and work out what the clinical syndrome is before we start using any test. These tests are not for cognitively unimpaired people. They are only for people in whom you have noticed objective clinical changes, which is why it's so important to do that clinical assessment. These tests are not a dementia test. Dementia is a clinical syndrome that we need to define. They can help us to identify the pathology. They can help us identify Alzheimer's disease pathology, but they're not testing for any other pathology. And so we need to be cognizant of the fact that there are other co-pathologies or other pathologies that might be affecting somebody's clinical syndrome. And so that might mean that we end up referring people, even if they have a negative result, because of those other pathologies. But the purpose of doing the test enables the person to get to the right place at the right time. So my personal reflections are, I think this test can be helpful for people. I think it can help guide our treatment decisions. In my personal experience, it has improved my confidence and my clinical reasoning for identifying symptoms, and particularly thinking about that in the context of Alzheimer's disease, but also for those more challenging consults where you're not sure whether something is mental health related or other pathology related, then applying the test can be really helpful. And I think it is possible for primary care to be able to use these tests with the right level of education and support and collaboration with other specialists. Thank you for listening.
Thank you, Dr. Daly, for this fantastic talk. It's amazing to see how much can already be done at the general practitioner level. This is very helpful. So let's first move to the polling questions. All right, so what do you think now? How can digital cognitive assessments support earlier detection of cognitive impairment in clinical pathways? Do you think they can A, replace the need for clinical evaluation entirely? Do you think B, they function only as research tools and are not suitable for primary care? Do you think C, they enable accessible pre-screening, helping clinicians identify individuals with early cognitive impairment? Or do you think D, they cannot provide alternative or additional information over pen and paper screening cognitive tests like MMSE? And I give you again a couple of seconds to reply. All right. And about the blood-based test, what is the key advantage of high accuracy blood tests such as plasma beta-217 in the diagnostic workup of suspected Alzheimer's disease? Do you think they can fully replace CSF and PET in all diagnostic situations? Do you think they provide a method to rule out or rule in amyloid pathology, enabling earlier identification of patients likely to have AD? Or do you think maybe C, they are mainly useful only for triage and cannot support diagnosis? Or D, they are unaffected by comorbidities such as kidney disease? So let us know in a couple of seconds what you think. And to provide you the correct answer, the previous question was answer C, and the question on blood test is answer B, the correct one. All right. And we're back to the Q&A session. So thank you again very much for your talks. So what I take from your presentations is that we need to try to identify mild cognitive impairment as early as possible. And digital cognitive assessments will let us to detect this very early cognitive impairment. And the blood-based biomarkers such as p-tau217 let us be this first line of confirmatory diagnostics that are, first of all, accurate based on the COI criteria, and they are also, simple and cheap and fast from the patient perspective, right? So having this in mind, I was thinking, so when you receive a general practitioner level, primary care, such patient who is MCI based on the, cognitive assessments test and is highly positive on p-tau217 blood test, what do you do with such patient?
Well, I guess it's telling you that the person has, potentially a significant illness and they need to go and see a specialist so they can have further testing that might be able to access them, treatment sooner rather than later, because the earlier that you treat someone, the better. So I would be getting that person into a specialist as soon as possible, really.
And what would you do at the specialist level?
So it's, first of all, it's really a call for action. So if you establish mild cognitive impairment and there is evidence that amyloid pathology contributes to it, then it's a call for action. Time is brain. So referral to a specialist and the memory clinic as fast as possible is important. And it's great that, these patients can now be faster identified at the GP level. And the specialist has to look for other etiologies and also establish, for instance, the presence of tau pathology before then treatment can be initiated.
All right. So thank you very much. And now let's see the questions from our audience. So we've got, it looks like, 27 countries participating.
Wow.
And there is a question from Switzerland. So let's see. So in your view, what's the single best reason people with early cognitive change aren't getting picked up? Is this the time in clinic, awareness, or pathways themselves?
I think if it was just one thing, that would be easy, right? So we know all those barriers exist. I mean, what I think about new treatments and new blood tests is that it's all ways to empower us as clinicians and also the patients. So they'll come asking about things and hopefully we'll be able to have the knowledge and dedicate a bit more time to discussing, their cognitive concerns.
Got it. And let's see, what's the other? There is a question from Portugal. So what is the role of the clock drawing test and the mini mental state examination in the primary care setting for the diagnosis of cognitive impairment? Should these tests be repeated over time? Should digital cognitive assessments always be used? What do you think?
Well, I think that, these tests were primarily designed to pick up people with dementia. So for mild cognitive impairment, they're not sensitive enough. If they show a signal, then one should act upon it. But if they are normal or, near normal or borderline, particularly the MMSE, one should really do a further assessment. This is also what the guidelines say. If somebody has a history that's compatible with mild cognitive impairment, normal performance on the MMSE cannot rule out MCI, one should look further.
Yeah, I think it's about taking all of that information. So our history examination, it's all part of what we do. And if the history doesn't match what you're finding on the examination, then you need to look at other tests. And so that's a really good way that these digital cognitive assessment tools might come into play. It's more information for us.
Got it. And let's see for another question. We've got a question from Greece. For example, this is a difficult one. Will the patient be patient enough to perform the test in a period of time? So not everyone understands the importance of something like this for, sticking long enough of one test. What do you think?
Our experience, and there are, of course, a lot of feasibility and validation studies regarding adherence, and our experience has been very positive. So people, once they have started, they remain engaged. They want to contribute to the assessment. They actually feel empowered by being able to actively contribute to the diagnostic process. And there have not been really problems with adherence rates. But of course, it's important. I think the way the clinician and the patient talk about the importance of digital assessment to begin with is an important factor for adherence.
I think we have to appreciate people are actually genuinely worried and they want to have their concerns listened to. And so that's probably why they spend time doing the cognitive assessments, because it's something that they want to find the answer to, right? So they're engaged in the process.
Got it. All right. And let's see for the other question. There is another question from Switzerland. So the case that was shown in Dr. Duzel's presentation shows the test ruling out rather than ruling in. In your experience, how often does a reassuring result like this turn out to be falsely reassuring on longer follow-up? Trying to gauge how much weight to put on a normal test result, right?
Yes. So very good question. So I think even with a digital cognitive assessment, a normal test result needs a follow-up investigation, because the patient that has a history of memory complaint and does not yet fulfill the criteria for mild cognitive impairment may still be on a declining trajectory. So I would recommend to do a follow-up assessment after 1 or 2 years, and always check on the patient.
I think, it's highlighting again that no single test, no single thing is going to give us the answer to this complex question. And we need to continue to ask the right questions of the patients, ask the questions of the collateral historian, and put all these pieces of the puzzle together. So, and not forget about the person, okay? Because we know these conditions, they deteriorate over time. And so we can use time as a tool sometimes. We can, monitor people over 6, 18 months, whatever it is, to see whether there has been a change in their clinical state.
All right. Thank you very much. And there is one more question, and this one is about chronic kidney disease. So how do you think chronic kidney disease would affect beta-217 levels?
So there's been a lot of data looking at the ways that other things can affect the result. And we know that if you have severe kidney disease, so an EGFR less than 44, 45, then it's likely to affect the result. And we also know that there are some effects from BMI as well. So people with a BMI over 30. So again, no test that we use is 100%. There are always going to be things that affect the test result. And I think it's about identifying the right person in whom to do the testing in the first place. So somebody who has symptoms first of all, and then taking into account these other things that can, affect the result. And even if you did it in somebody who had chronic kidney disease, there are still other tests that we can use to confirm, right?
Absolutely. So I think, if somebody has multiple metabolic risk factors, then maybe these are instances where earlier referral to a specialist and doing other types of biomarker assessments may also, save time and be helpful.
Got it. All right. So, let's see what question do we have. There is a question about access. So, if you could tell us how accessible is Neotive Care?
Yeah, so the one aspect about Neotive Care is that the tests are language independent, so they are available in many different languages. It's a medical product, so the medical product needs to, in different countries get into the App Store, and this needs to pass through some regulatory processes. And so I think for physicians who are interested in using, just reach out to us and we can tell you what the timeline is for each country.
Got it. All right. So I see we've got the time for the very last question. So here, I'm thinking, what is your last message to the audience, if you would have, one thing to sort of say?
Always take cognitive concerns seriously, really listen to the patient and, never dismiss someone's worries.
Fantastic. And from you, Dr. Duzel?
Yeah, I completely agree. We are experiencing a paradigm shift. We should take cognitive concerns and mild cognitive impairment very seriously in Timeless Brain in this instance.
All right. Thank you very much. This was a wonderful discussion. I feel we could go on for way another hour, but we are up, I think, with our time. So before you will leave us, you can answer the quality assessment and tell us how did you like this webinar. And with this, I would like to thank you for tuning in, staying with us for this webinar, and goodbye from Geneva.